Hi, I'm Dr. Christopher Bunick, Associate Professor of Dermatology at Yale School of Medicine, and your Editor-in-Chief of Dermatology Times. So precision medicine and atopic dermatitis, there's a lot of moving parts right now. We've seen gene expression profiling come out to try to understand Th2 profiles versus JAK inhibitor profiles. It's a step in the right direction. I think there's a lot more that needs to be done to get to precise pharmacogenomic prediction. We're not quite there. We have numerous other types of therapies outside of biologics and JAK inhibitors in development, including STAT6 targeted agents, particularly degraders. Understanding how different types of therapies are going to be predicted to work in certain patients, it's going to take a lot more understanding of what drives atopic dermatitis. For example, understanding how OX40 ligand targeted drugs or any other drug, whether it's JAK inhibitors or the other biologics that are currently approved, how they may or may not cause disease modification requires us to actually study how are memory T cells affected over short and long courses of therapy. How are they affected? And when you think of T regulatory cells, how are they affected over short and long periods of time with the different therapies? And then ultimately, when you think of at least potentially the inciting event, antigen presenting cell interacting with activated T cells, what's regulating that? And are there feedback loops that are coming from the different therapies? In order to dissect out this pharmacogenomic approach and being able to give a specific therapy that you know will work for a very certain patient with AD, it's going to take a combination, I think, of gene expression profiling, further understanding of proteomics, further understanding of the immunologic cells that are driving disease. And that full map may give us some more insight into what therapies are best. Right now, some of the science that we have, and one of the reasons that so many people use JAK inhibitors like upadacitinib as a benchmark is because when you look at lymphocyte activation assays and you look at which therapies can regulate or downregulate type 1, type 2, type 3 cytokines the most, all the biologic therapies are continuing to try to hit the benchmark that upadacitinib has set in that particular assay. And when you combine the closest biologic therapy in that assay to date, in terms of suppressing type 1, type 2, type 3 cytokines, is the combination of IL-13 and an amlitelimab-like antibody. And this shows that we are sort of chasing this idea of that more comprehensive cytokine suppression is better. What we don't have, to come back to the immune cells, and what we're seeing with other types of therapies, particularly REZPEG targeting IL-2 and some of the Treg cells, cellular-based therapies can also give us a lot of insight into how we modulate the immune system upstream of the cytokines can be incredibly important to this concept of disease modification and long-term disease control. And that's where I'm looking over the next couple of years in atopic dermatitis. I'm very interested to see how the immunology, the cytokine biology, and then the transcriptomic proteomics and prediction, how all that can integrate together. It truly is, to come back to our Derm Avengers theme, it's integrating teams together, integrating approaches together for the betterment of patients.